Appalachian Wellness for a new tomorrow and a new you. Our specialty is you. I'm Raymond Oenbrink, the president and owner of Appalachian Wellness. We're going to talk today about chronic inflammatory response syndrome and toxin binding using cholestyramine, abbreviated as CSM, also known as Questran, or Colsevelam, also known as Welchol. Cholestyramine is an anionic binding agent that's taken by mouth. It disrupts enterohepatic circulation by absorbing bile, preventing its reabsorption in the ileum and hepatobiliary recycling. Boy, that's a mouthful. Basically, what this stuff does is you take it about 30 minutes before a meal, chase it with a fairly large glass of water to get it out of your stomach and into the first part of your small intestine, the duodenum. That's where the stuff works. If you have a gallbladder, during a meal, your gallbladder basically contains bile, which is a detergent that's designed to emulsify or break up fats in your meal so they can be absorbed easily. Bile contains toxins that came from the volatile organic compounds and other things that you've been exposed to as you've become afflicted with CIRS. And the bile normally will go into the upper part of the small intestine, the first part of the small intestine, the duodenum, and then get reabsorbed in the last part of the small intestine, which is called the ileum, and the portal vein will take it back to the liver for recycling. That's normally what happens if you have a gallbladder. If you don't have a gallbladder, you're constantly dripping bile into your gut, okay, to absorb whatever fats may be present. When you take the cholestyramine, this stuff binds the toxins and the bile so it does not get reabsorbed and make its way back to the liver, and it's excreted from the body in the stool. So it's a very good thing to have this stuff. These toxins are, again, excreted by the liver into the bile system, the biliary system, which then dumps it into the duodenum, the first part of the small intestine, and gets reabsorbed and recycled from the ileum, the distal last part of the small intestine, so it can go back to the liver and repeat the process. And these medications basically bind the bile and the toxins, helping the body to excrete them in the stool. These medicines are somewhat constipating, okay? This can be improved using osmotic laxatives such as polyethylene glycol, also known as Miralax, sorbitol, and magnesium. Cholestyramine is taken as a 4-gram packet about 30 minutes before meals and at bedtime. It actually contains 4 grams of anhydrous cholestyramine, pure cholestyramine without water, and another 9 grams of cholestyramine that may have some water within it. It's a dry orange powder. It's got a bit of an orange flavor to it. It also got sucrose or table sugar in it because it's not a really good tasting stuff. If you choose to use the Colsevelam, the Welchol only has about 20% of the effectiveness at binding these things as cholestyramine. So in theory, it'll take 5 times longer to get the same effect. So if it's possible for you to tolerate cholestyramine and you want to get better faster, which is what I'd certainly recommend in a terminal illness that's trying hard to shorten your life and causes a lot of suffering, it's a personal choice. Do the best you can. Some people will alternate. Take a dose of cholestyramine, follow it with a dose of Welchol at the next meal, then cholestyramine, then Welchol at bedtime. And that's perfectly fine too. It's an individual choice. Medication should not be taken 2 hours before or after each dose of the cholestyramine, as it can interfere with air absorption as well. Cholestyramine aids in the excretion of biotoxins from the body, thus reducing the overall toxic load that's triggering the immune system's complement system and the cytokine activation pathways that the ineffective T regulatory cells are unable to rein in and bring back under control. The broken off switch, if you will. This will help to reduce the C4A and the C3A. And there's some references to that information as far as these drugs are concerned. Not everybody, again, will tolerate the cholestyramine. It can be difficult to take properly. And the alternative would be the Welchol, 1,875 milligrams twice a day with meals, which absorbs about 20% of what the cholestyramine is able to absorb. And again, we can alternate one and then the other. C3A can also be reduced by high doses of statins, such as simvastatin, 80 milligrams a day. This is a cholesterol-lowering medication. These drugs tend to reduce the body's resource ubiquinol CoQ10, which is essential for metabolism. It's basically how the cells in the body, the mitochondria in the cells, burn fuel and oxygen to get water and carbon dioxide and energy. So it's a good idea to take at least 150 milligrams of CoQ10 if you're going to be taking a statin. And recall as a practitioner that medicine is an art. If somebody's had a prior difficulty taking statins and they want no part of going on it again, you've got to respect the patient's right. Statins can cause severe muscle damage, so if somebody's had a problem with that in the past, I can certainly understand their reluctance to go on a statin in the future. C3A will also decline with our other interventions, though. So if you have an elevated C3A level, statins are not the only choice that we have. We do have other options to bring that down. And there's a bunch of references available here too.